discussing the chapters for the final exam. I believe there are 4 chapters: routes of administration, parenteral dosage form, osmolarity calculation, and flow rate calculation. So this is kind of a very quick review, what to expect in the final exam, what is important, what to focus on, and expect around 50 to 55 questions, 2 hour, and then it's like 50% theory, 50% calculations, because we have 4 chapters, 2 calculations, 2 theory. Routes of administration is half. I think we covered up to the oral dosage form in exam 2, and from parental dosage form onwards, it will be part of your exam 3. So let's start. In between, once I upload this video, if you have any questions, you can write me an email. We can set up an office hour via WebEx on Thursday, as well as in-person office hours are there from 1 to 3 p.m. on Friday. So let me share my screen and we can start. I'll stop my video just to cut down the MBs on just. You can see the screen. We'll start with the parental route of administration. From this slide onwards, you have to read it for exam 3. So parental route of administration, as we discussed in detail into the class, the advantage and disadvantage, expected question compared to the oral dosage form and another dosage form. What are the advantages and what are the disadvantages of this parental route of administration, which includes especially IV, subcut, and intramuscular, and what kind of dosage form is applicable to each route of administration, especially for the parenteral. So here, I think read more in detail the explanation. So before you begin, you should have a classroom notes, whatever we discussed in the class, as well as the book, Ansell's Pharmaceutical Dosage Form. So I clearly mentioned during the class what you have to read from the slide and what you have to read from the book. So make sure you have that. Subcutaneous tissue, the site of administration, the volume, why sometimes we use vasoconstrictor to control the release of a drug by subcutaneous administration, as well as what kind of dosage form you can give by subcutaneous route. That's given. Most probably we do aqueous as a solution, and then both subcut and intramusculars are used for a depot injection, which are either suspension or oil-based preparation or polymeric or microsphere kind of particles, where we use for 1 month or 2 months of or a year long depot injection. At the bottom, you would see the intramuscular route, the volume, the precautions we have to take while doing IM injections, as well as what are the different applications. IV bolus, IV infusion, what are the difference? What are the formulation? Usually we give only solutions and emulsion dosage form by IV route used for the diagnostic purpose. So IV, anyways, we have a detailed chapter on that. So that's where we will learn it more in detail. You need to know the fundamental difference between topical and transdermal route. One which stays in the skin and treat the skin illness, as well as transdermal, where you expect the site of action is not the skin, but site of action is somewhere else, maybe heart, maybe brain, or systemic action. So the drug is expected to cross the sternum corneum, enter into the bloodstream, and then work somewhere else in the body. How the drug permeate. This is one of the very important slide where we understand how drug permeate into the skin versus any other part of the body. If you give any drug which cross the skin, dead layer of cell, and that's why it is mostly intercellular, while when we talk about intestine or any mucosal permeation, it's mostly intracellular. It goes by passive diffusion or paracellular transport. Correct? So this is what we have discussed in detail, the permeation pathway of a drug into our body. Form, gels, cream, ointment, lotion, paste. You should know the difference in their, like by definition, what is the difference? in detail, the composition of each of these dosage form will be discussed into Pharmaceutics 2 next semester. Transdermal, again, we have a dedicated chapter on transdermal technology, how we make this transdermal patch, what are the ingredients we use, characterization, everything into Pharmaceutics 2 next semester. So here, in general, we will just understand the advantages and disadvantages of the transdermal patch or transdermal route of administration. And that's what we have discussed in the class. So make sure you can expect 1 or 2 questions on why to choose transdermal patch over oral dosage form for some of the drug molecules. Let's say nitroglycerin available as a transdermal patch, same available as sublingual tablet. So what are the advantages if you give transdermal route? Same as nicotine, available as a gummy, available as a patch. So you should understand why we choose one route over another route in what case. And the limitations is like the drug with the higher dose or drug with the requirement of high plasma concentrations are not suitable. You cannot give paracetamol or amoxicillin by transdermal patch because they require high blood concentration for the action. And what are on the limitations that we discussed into the class. The route of administration, which are local, mostly eye, ear, vaginal preparation, they are not for systemic purpose. However, nasal is mostly local, but some of the doses from like calcitonin are given for systemic purpose. So, and we discussed what is nose to brain. Some of the formulations we have, we deliver the drug deep into the nose and then it enters into the brain. How it enters into the brain, what are the mechanisms, that pretty much we have discussed in the class. So I hope you remember. You might see a question on that. Pulmonary route of administration, we discussed aerosol, metered-dose inhaler, dry powder inhaler, very in general. You don't need to go more in detail because that's part of Pharmaceutics 2. Right now, we will just try to understand what is pulmonary delivery system. And that's what we have discussed in the class. That's the size which is required to enter, like 5 to 10 micron size of particle. So this is more of a particle size engineering we have to do when we wish to deliver something by pulmonary route, whether it is local pulmonary action or it is for systemic absorption. We discussed those examples starting from corticosteroid to insulin, a drug for asthma, and all that. So advantages and disadvantages of pulmonary route. There are some summary. I would strongly recommend you read the summary of advantages and disadvantages of each route. So basically, if for final exam, you can definitely expect the advantage or disadvantage compared to the another route. So your questions might be like example based question, that this is the drug, this is the profile, and then what do you think, what route of administration is the most suitable for this kind of drug, correct? So you will see that kind of question as well as you will see straightforward question from the slide. So that's pretty much let me more or less we discussed this thing into early into chapter 5, the Cmax, Tmax, AUC. We took it out for the exam 2. However, we will consider this thing for exam 3, that the blood, the drug concentration in the blood rises, as you can see here on the blue line. At one point, no more drug available in the intestine, and liver continuously metabolize your drug. The drug concentration in the blood goes down, and after a while we plot a graph, average serum concentration or average plasma concentration of drug versus time, and that's where this is called pharmacokinetic profile. The detailed calculation of area under the curve, Cmax, Tmax, the equation associated it, we will do that into biopharmaceutics. So here is just an introduction. What is Cmax? What is Tmax? What is AUC? And how it is really important to calculate, correct? And then we also discussed the minimum effective concentration or tolerable concentration. It has to be within this window. So let me just go over it real quick. Uh, Chapter 5, bioavailability. There are two kinds of bioavailability, absolute and relative. When we compare something with the IV dosage form, that's called absolute bioavailability. If you inject 100 molecule by IV route versus you give 100 molecules by oral route, how many of those molecules is really reaching to the blood? Some may insoluble, some may not permeable, and some molecule may subject to the pre-systemic or first pass metabolism. So whatever is left over reach to the systemic circulation, that is considered for the bioavailability. And then we use area under the curve to calculate. That's what we use to calculate the bioavailability. AUC by oral route, AUC by IV route multiply by dose of IV divided by dose of oral route. So this is absolute compared to IV. And when we compare two different doses form or different route, the bioavailability of A to B, that means bioavailability of a tablet compared to transdermal patch, that's when we use the relative bioavailability. Or if you give by oral route, bioavailability of solution versus tablet, that's when we use the relative bioavailability concept. Parental doses form, we discussed more in detail, like in the class, what is pyrogen free and what is sterile, correct? So these are the different kind of doses from starting from single dose vial, multi-dose vial, ampule, and large volume parenteral. What is pyrogen, lipopolysaccharide or bacterial endotoxin, how it change or lead to the fever, and why it is really important for us that we should not have any kind of pyrogen into our formulation, or it has to be below a limit which is specified by United States of Pharmacopoeia. Correct. So IV push or IV bolus versus IV infusion. The piggyback concept I explained very well in the class. What is piggyback? And then how do we use it in the calculation? You don't need to memorize the angle of these injections, but you should know in general how we give this dosage form. Advantages of parenteral route. One or two questions from it. The complications associated with the parenteral dosage form, especially intravenous dosage form. Category of injection, it could be mostly solution, then dry powder for reconstitution, but then the drug is not stable in aqueous fluid or stable in water. We supply as a dry powder, and right before the injection, we reconstitute it with water for injections or saline, and then we inject it. One solvent is water for injection USP, sterile water for injection. As I said, there is always endotoxin limit. It is very difficult to completely eliminate the LPS or endotoxin from the formulation. However, it has to be below certain level for it to not create any sort of fever or that kind of complications or toxicity associated with the LPS. What is bacteriostatic water for injection? What do we use? What kind of agent we use as a bacteriostatic agent, and what are the limitations? Very nicely explained in the class, and as well as very nicely given in the book. What are the toxicities associated with it? I would strongly recommend you should read that for the final exam. Sodium chloride, Ringer solution. What do we use? Don't go more in detail like factors. These are just for your information. But yes, we use vegetable oil either by IV route to give as an emulsion or by intramuscular route to make a depot formulation. We use corn oil, cottonseed oil, peanut oil, sesame oil, or water miscible substance, glycerin, PEG, propylene glycol, ethanol as a solubilizer. Realization, one of the very important part of your final exam. About the sterilization by ionization, which is gamma radiation. However, we will discuss the method, and then we have to verify whether it is really the the material is really sterile or not. So we'll start with the steam sterilization. I am sure by now you must have seen autoclave through your PP1 lab. And for all the four methods, how it kills the bacteria: coagulation, inhibiting the metabolic process, oxidation, or what kind of, by what mechanism it really kills the bacteria. That you will see definitely a question. So read in detail which sterilization method is more effective compared to other. See their timings, how long each method will take. Steam will take 20 minutes, dry heat might take 2 hours, ethylene oxide might take even 14 to 16 hours or something like that, right? So these are some of the comparative analysis of each method, as well as what you can sterilize by a particular method and what you cannot sterilize by that method. You will definitely see one or two questions on that, because that is one of the key aspect of this sterilization part. That does it has water, is it oil, it is heat stable, it is not heat stable. So all this thing comes into the picture, explained in the class as well as given in the book. So I will strongly recommend you should read that, what you can sterilize, what you cannot sterilize. I repeat, I think Ansel's pharmaceutical dosage form, everything is going very well. Sterilization by filtration, you don't need to go more in depth about the make of the filter and everything. It is just you should know what size of filter we use for filtration sterilization, as well as what is the advantage and disadvantage of filtration sterilization compared to, let's say, steam sterilization, correct? So mostly we will see steam sterilization in the pharmaceutical field, unless until the material is not really stable at 121 degrees Celsius. Volume, we do sterilization by filtration. Gaseous sterilization, sterilized by gas sterilization, what we cannot, and how it really kills the bacteria. That is very important. What is the effect of humidity and temperature? So I would strongly recommend you read that. What is pyrogen? How it affects? I think we discussed that into this, I think, slide 3. What are the 3 methods? Again, I don't expect you to go more in detail, but you should know in general how we separate the pyrogen. And then what is Lal test? I shared a video with you. You can still see that video. What is the mechanism of this Lal test to detect the pyrogen in our formulation, and how it really replaced the rabbit test, which is very classical test for pyrogen testing. So sterility test is one of the very important sterilization chapter. So how, when you do a sterilization and let's say you filter it, do you really think it is sterile or not? That we have to do a validation, and that's where these tests are given in USP. This is how you perform a test to validate whether whatever you sterilize is really sterile or not. Pyrogen test by Lal test, clarity. We have equipments to check whether there are particles into it or not. And liquor test, I think we discussed, is when you seal the ampule, there is always a chance that it might not seal completely. So we have to do that as well. Types of ampule, vials. You might see the, you might see, not might, you will definitely see one question on ampule, one question on vials, advantage, disadvantage of each of them, correct? The coring, what is coring, how it happened, and what could be the reason of coring into the rubber stopper. So that is important for you to know. Disadvantages we discussed into the class again. In which condition we use what kind of glass, that could be a question. So try to understand what is type 1, what is type 2, and what is type 3 kind of glass, and what it is used for. Plastic container, how they are better than the glass container, and what kind of plastic we use. Label, that's what are the labeling instruction on the parental dosage form. It is different from what we use as a injection solution. What is peritoneal dialysis and what is hemodialysis, that we have discussed more in detail into the class, and then how it is really helpful to us. So with that, I guess that's pretty much it is. I would say it is very straightforward. Read the slides, read the classroom notes, and then read whatever I ask you to read it from the textbook. Make sure you read it. And I really don't see any trouble with this for the final exam. Now, since we learn for IV fluid, this is as miles per hour calculation. If you have to drive 600 miles, you are driving at the speed of 60 miles per hour. Are as simple as that. Or the mileage of the car is 25 miles per gallon. If you have 10 gallon, how long you can drive, something like that. So make sure, do not get confused in all this thing. In addition to that, flow rate, again, this is very simple. Time of infusion is total infusion volume divided by the flow rate, or flow rate would be volume divided by the time. However, the next step is based on the drip set we use, ml, 15 drops per ml or 20 drops per ml. Like each ml turns into how many drops? We have this equation. Again, equation will not be provided in exam, and I don't see why I should provide it, because again, it is like ml divided by time, that is how many ml in how many minutes, multiply by each ml turn into how many drops, correct? So that is the rate of flow into drops per minute. So you understand it, great. If you do not understand it, I'm sure the way we explain the class, by now you know there is no need of equation here. Understand what is NS, normal saline, half normal saline, D5W, what is that? It will be helpful in calculating the osmolarity. If I ask you this thing, we have a two drip set will always be provided. So in this equation, I will always provide you with the drip set. How many drops per minute you will inject this to finish the infusion within certain time frame, let's say 5 hours or 6 hours. Or I will provide you the volume, I will provide you the drip set, and I'll tell you, inject this within 5 hours. So what would be your flow rate, correct? So either way, either I will ask you drops per minute or I will ask you the time. And always the ML and drip set will be provided, correct? So I think this is straightforward. You can expect this kind of question here. 50 ml. So that is, we are talking about total 3000 drops, correct? And then each drop per second. So 60 drop. So what would be the time, how long it will take, correct? So this is why we calculate all this thing. Again, it is as simple calculation as your miles per hour calculation. Make sure you do not lose point into, just try, understand, and then I'm sure you'll be able to solve it. So here, 1 drop per second, 60 drop per minute, and that's how you end up calculating what will be the total length of time in minutes. Equation, or you can directly understand. First, you have to convert pounds, 3 pound 8 ounce into kg. Calculate the dose, how many ml per day. 60 drop per ml, and the 20 drops per minute, your infusion rate. So how long it will take? As I said, you will be given volume, drip set, and flow rate. So what you have to calculate is just, sorry. Any problem? This is related to the dose calculation first. First, I will ask you to calculate the dose based on the information provided and then turn into the volume, correct? So 2.5 mg per kg, 1.5 kg neonates. So what would be the dose? That will be the question A. And then the B would be, if they are in 50 ml of bag, Run for 30 minutes, 50, 30, that is how many ml per minute. And then next step, if I tell you, if I provide you the drip set which 20 ml per drop, 20 drops per ml, how long will it take or something like that? A piggyback concept where you add your amphotericin B into, and then I think one of the problem, I think in the next couple of slides, we will see how you can switch from piggyback to the large volume and then vice versa. This kind of equation in the file, you have IV piggyback. So the flow rate we have to calculate, the total flow rate will be 10 drops per ml. The volume of IV piggyback is given 100 ml, 100 ml for 1 hour, every 6 hours. That means total 400 ml in a day that you are injecting. Every 6 hours means 4 times a day, 100 ml, 4 times a day, 400 ml. Correct. But again, for individual 1 hour, you are injecting 100 ml drops per ml, 60 minutes. Correct. So in 1 hour, you are injecting 100 ml with the drip set of, and that's how you do the calculation of flow rate. Total flow time will be 4 hours, total volume will be 400, and then you subtract it from 3000 ml of your IV fluid. 20 hour, you will run the main line, that is IV fluid line, and that is how you can calculate the flow rate for D5W. Again, if you have any confusion, write me an email. Otherwise, see the classroom notes. We have discussed this calculation very much in detail. I gave you homework as well. I hope you have done that. If you have done that and if you got the right answer, I'm sure you will do well in the exam. If not, then learn it. Calculation in the final. This is just we did in the class, because if I give you this, I have to give you equation, and then plugging the number is not fun. You'll definitely see this kind of question in the final, because this is again in the hospital setting or USP 797 facility where you have to prepare 30, 100 ml of epidural bag, for example. We did give you some homework as well. So there are multiple ways you can do that, but the basic concepts remain the same. You have to prepare this many number of bags. Each bag should contain this many ml, and the concentration of drug would be given. Again, so you calculate what will be the total amount of drug you need. You go back, check your inventory, and see you have a stock solution. This is basically the chapter 5, stock and dilution. So this is exactly the same thing. Your drug is available as a concentrate. How do you use that drug concentrate? How many ml you will withdraw from that vial, and you put it into you are making, let's say, so 30, 100 ml. Let's do a real quick. Let's say 3000 ml you have to make. Usually we make little extra just to make 30 bags, correct, at the concentration of 0.125. Example of C1V1 C2V2. So if you have a stock solution of 0.5% ml, we need in total, so we I think roughly need 750 ml of bupivacaine, 0.5%, correct. Each vial contains 30 ml. So for 750 ml, how many vials? Again, I'm sure this calculation I don't need to explain. You know it since class 1. So there are 25 vials, correct? Or other way around, if you want to go by weight, that okay, 3000 ml, 0.125 prepare at the concentration of 0.125% weight by volume. That is nothing but 0.125 gram in. So that many grams you need to make 3000 ml of 5% bupropion. Now with that gram, you go to your inventory and check, you have 30 ml vial, 0.5%. I gave you direct conversion, 0.5% bupropion or anything is nothing but 5 milligram per ml, correct? Vial. Each vial contains 150 milligram of bupivacaine, correct? So one vial contains 150 milligram of bupivacaine. How many vials you need for this many grams of bupivacaine? So either way, you go by amount, you go by volume. I'm fine with anything you do, provided you get the right answer. Next problem is the fentanyl citrate. I think we did a couple of example and the practice as well. So I'm sure you will not lose point into this kind of problem. For your information, we did calculation, but I will not ask you any question in the final. You will definitely see one question on. Sure, you are expert now into Henderson Hasselbalch calculation, so I do not see any concern there. The last part. Tonicity and how it really affects. So it is not only the concept or mathematics, you have to understand, since I'm mentioning class one, why it is important, why these concepts are important. That is where it is important that you understand the concept, and when the time comes, you apply into a real practice. So as we discussed, I gave you an example of student in the classroom versus number of chairs versus student in another classroom versus number of chairs. That's basically a simple explanation of osmolarity and tonicity. So ions cannot go in and out across the semipulbar membrane. However, the water can. So the water will follow the ions. Wherever there is a higher concentration of ions, water will follow. And based on that, we will see this changes. As I said, this only applies to the solute that do not cross the semipermeable membrane, which is ions in our case. What to do when the solution is highly non-isotonic, whether it is hypotonic or whether it is hypertonic. We have to do all this calculation. Again, this is very much critical for nasal solution. If you see, nasal spray comes as 0.9% sodium chloride, so as ophthalmic preparation. For parenteral, it's 5 liters of blood we have. So 510 ml of water for injection, though it is hypotonic, the blood will adjust it. But for ocular and nasal, we have to be very sure that they are falling into the same osmolarity. If you are doing large volume, 100 ml, 200 ml by IV route, then yes, we have to make sure that we give it by either saline or either dextrose. But if you give 1 or 2 ml of injection, water for injection should be fine, though it is non-isotonic. Correct? Again, very fundamental. You know milliequivalent, you know milliosmol. They both are related to the molarity. However, milliequivalent is a dose term. Like if you give 100 milligram of sodium chloride, sodium acetate, and sodium citrate, the amount of sodium our body receive is not the same because their molecular weights are different. So we use valency into the milliequivalent calculation, while in case of milliosmol, we consider the number of particles. If it is sodium and chloride, we multiply it by 2 because sodium and chloride, there are 2 particles. However, in milliequivalent, sodium has valency of 1. So let's say plasma, it is again 154 millimole per liter, 154 milliequivalent per liter sodium, but osmolarity is double, like 308, right? So all this thing is, again, we discussed into the class to make you understand how the concepts are different and the applications are very different. Calculate molarity, milliequivalent osmolarity. You will definitely see one question on normal saline. I will give you a concentration and I will ask you and then osmolarity. Gram per liter divided by molecular weight. And that's where from no matter I give you percentage, I give you milligram per ml, you always convert that into the gram per liter and divide it with the molecular weight that give you molarity. And then a particle it represent, you multiply by 2, 3, or 4 that I will provide you in the exam. Again, if you see dextrose, there is nothing like milli-equivalent. So milli-equivalent concept only applies to the electrolyte, not to the drug or anything which does not dissociate or basically sodium, potassium, calcium, magnesium. That's where we use the milli-equivalent concept to represent the dose of it based on the source of it, sodium chloride, potassium, sodium acetate or sodium citrate. Osmolarity on the other side, molarity multiplied by number of particles. Dextrose does not dissociate, so it's just one. Again, this is 5% dextrose, the osmolarity will be the same. Even if you use 1 ml of dextrose 5% or 1 liter, the osmolarity of D5W will remain the same because it is milliosmol per liter. 0.45%, which is, again, we did the calculation in the class. However, when we talk about milli equivalent, you have to see this 500 ml into the account. So I strongly recommend do not use equation for milli equivalent. I told you 1 milli equivalent of anything is its molecular weight in milligram divided by the valence, correct? Here, molecular weight is 82 gram per mole, which is, again, when we use milli equivalent, we convert that into milligram. So it is 82 milligram divided by 1, which is sodium 1, correct? And sodium acetate. And that's when 1 milli equivalent is 82 milligram, 10 milli equivalent, 20 milligram. 820 milligram is present in 500 ml. So per liter, how many milligram of sodium citrate will be present? Convert that into the gram and divide that by 82. That will give you millimole, and millimole multiplied by 2 particles, sodium and acetate, correct? So again, this is just a revision. See the classroom notes, and then when you add dextrose, sodium chloride, and sodium acetate together, that will give you the total osmolarity of this solution. Mannitol, correct? The dose will be given in gram, but that many gram present in how many ml that you have to calculate, and that many ml divide by the time, that will give you the infusion rate, correct? Osmolarity, we did this calculation. Again, this is important, but not a part of your exam. We did discussed ophthalmic, the dose when aqueous humor, like front of the eye, that we give antibiotic, anti-inflammatory, and those kind of molecule, or maybe for glaucoma. For back of the eye, what kind of injection we give? This is just your introduction. That's to the AMD or that kind of disease we give back of the eye injection. But mostly we'll talk about the front of the eye. That's the solution, ointment, suspension, advantages and disadvantages. And this is again key calculation where osmolarity, we have to make it isotonic to the ocular membrane. So when it's a sodium chloride, it's 0.9%. However, some of the drug, it's not completely dissociate, like atropine sulfate, morphine sulfate, or pilocarpine hydrochloride. When you use 1%, they will exert some sort of osmotic pressure, and that's why we have to make sure that we accommodate that. So you cannot use, for let's say 30 ml, that is 9 milligram per ml. Sodium chloride for 30 ml to make it isotonic. However, when we add 270 milligram of sodium chloride plus we add the drug, the osmolarity will be higher than 308, and that's the reason we have to use this calculation called sodium chloride equivalent method. There are several methods we do this calculation, but right now we will restrict ourselves to the sodium chloride equivalent method, where 1 gram of drug is equivalent to how many grams of sodium chloride. So E value of atropine sulfate means 1 gram of atropine sulfate exert similar osmotic pressure as 0.12 gram of sodium chloride. And that's where we have to calculate how much drug. 1% means 10 milligram per ml. Again, do not disappoint me. I gave you the direct calculation whenever there is percentage to weight by volume. Either you can calculate 1 gram in 100 ml. So in 30 ml, how many grams? Or you can just go with 1% is nothing but 10 milligram per ml. 30 ml is 300 milligram. And that 300 milligram is equivalent to how many milligram of sodium chloride? And that much sodium chloride you have to subtract from the 270. That's what you need. And that will be your final answer, right? So you can definitely expect 1 or 2 question on this. The problem with the ophthalmic solution, as well as the do we use it, and what are the precautions we have to take, or the patient counseling when we give suspension or ointment, or those kind of things. What are the ingredients we use to make this preparation? And that's pretty much it is. So expect some questions, some theory, some calculations. And as I said, if you have any question, confusion, first you will refer to the classroom notes, and then you still have some confusion, you can write me an email. But I would strongly recommend first you refer to the classroom notes. During office hour, if you come and tell me, show me all the calculation, that's not possible. So do this calculation, and then if there is some confusion with the homework I gave you with the calculation, I think let me know. And in person, you can see me between 1 to 3 Friday. Stop the video here.